I'm Nadja Melosa, and I will be presenting joint mobilization techniques of the upper extremity. So I have a 38-year-old patient who presents with pain and reduced range of motion at the shoulder, elbow, and wrist after 7 weeks of wearing a cast from having an elbow fracture or dislocation. I will begin with the shoulder. Since he has minimal pain at the shoulder and has complaints of the shoulder feeling more stiff than painful, the focus of treatment will be to increase range of motion of the shoulder. Before the treatment, I am making sure that he is in a relaxed position, the head and neck is in neutral, and the shoulder is in an open pack position, or where it has the most joint play. For the glenohumeral joint, we have the concave glenoid fossa articulating with the convex humeral head. I have assessed the patient's active and passive range of motion, and now I am assessing the joint's beginning range, through range, and end range. To increase shoulder flexion, I am going to glide the humerus in a posterior direction. For increased range of motion, I am doing grade 3 mobilization, which is large amplitude into resistance or up to the point of limitation, and progress to grade 4, a small amplitude at the end of the range. To increase shoulder abduction, I am going to glide the humerus in an inferior direction. I have the web space of this hand just distal to the acromion process. To increase abduction, I am providing grade 3 large amplitude into resistance, and grade 4 small movements well into resistance. To increase shoulder internal rotation, the glide of the humerus is in a posterior direction. Treatment progression is to pre-position the shoulder into resistance, or to where I feel most restriction. So grade 3 large amplitude is up to the point of limitation, and grade 4 small movements well into resistance. To increase shoulder external rotation, an anterior glide is provided to the humerus, which can be done in prone or supine. The acromion can be stabilized with a wedge or a padding, and I am supporting his arm against my thigh, and I have the ulnar border of this hand just to the posterior angle of the acromion process. So grade 3, large amplitude into resistance, or up to the point of limitation. And grade 4, small amplitude, well into resistance, or at the end of the range. For the elbow, to reduce pain and increase range of elbow flexion, I'm going to first assess the joint and feel the restriction, and then distract the ulna and provide distal glide into physiological flexion. Since he has significant pain of 7 to 8 out of 10 and restrictions in range of motion, I will begin with grade 1 mobilization and then upgrade to the next grades based on his response and my joint assessment. To reduce pain and increase range of elbow extension at the radiohumeral joint with the patient in supine, a posterior glide is applied to the radius. I am going to stabilize the medial side and then use the palmar surface of this hand to provide a posterior glide to the radius. Grade 1 is small movement at the beginning of the range. Grade 2 is large amplitude free of resistance. Grade 3 is large amplitude into resistance. And grade 4 is small amplitude well into resistance or at the end of the range. To reduce pain and increase elbow rotation at the proximal radio-ulnar joint, I will pre-position into restriction. So I will feel for the radius and feel where the restriction is. And following the concave-convex rule to increase pronation, I am going to glide the radial head posterolaterally. Grade 1 is small movement at the beginning of the range. Grade 2 is large amplitude free of resistance. Grade 3 is large amplitude into resistance. And grade 4 is small amplitude at the end of the range. To increase supination, I am gliding the radial head anteromedially. So I'm going to stabilize the humerus. So grade 1 is small movement at the beginning of the range. Grade 2 is large amplitude free of resistance. Grade 3 is large amplitude into resistance. And grade 4 is small amplitude well into resistance. For the wrist, he is complaining more of the wrist feeling stiff rather than painful. So treatment will be focused on increasing range of motion. To increase wrist flexion at the radial carpal joint, I have my patient in sitting, but this can also be done in supine. At the radial carpal joint, the concave distal radius articulates with the convex proximal row of carpals. So I have my patient sitting with the forearm supported. This hand stabilizes the distal forearm, and the other hand grasping around the carpals. To increase wrist flexion, I am applying a posterior glide. So grade 3, large amplitude into resistance or up to the point of limitation. Grade 4 is small amplitude well into resistance or at the end of the range. To increase wrist extension, I am applying an anterior glide. So for a grade 3 mobilization, large amplitude up to the point of limitation. And grade 4, small amplitude at the end of the range. To increase wrist rotation, an ulnar or medial glide is applied to increase radial deviation. So for grade 3, again, large amplitude into resistance. Grade 4 is small amplitude well into resistance, so medial glide. And then to increase ulnar deviation, a radial or lateral glide is used. So grade 3, large amplitude into resistance. Grade 4, small amplitude well into resistance.